What's up, Ninja Nerds? In this video today, we're going to be talking about COVID-19. Again, as a part of our clinical medicine series, and if you guys are really enjoying them, hit the like button, comment down in the comment section, subscribe. You know the deal. If you want to see more, we offer more on our website. Go down the description box below. There's a link to our website. You can access things like notes, illustrations, quizzes, lots to go and check out there. All right, let's talk about COVID-19. So, probably last time we talked about this was probably 2021. It's been a while. It's been a while since we talked about COVID-19. This is going to be kind of like a little bit of an update, but it's going to, again, focus on the same style of the lectures that we kind of go through. So big thing here, etiology of COVID-19. You guys should know this. It's the SARS-CoV-2 virus. Now, when we talk about SARS-CoV-2, one of the interesting components about this is the genome. So what is it actually inside of this? So there's an envelope, right? So that's one of the interesting things about this virus is it has an envelope. And what does an envelope mean? All that means is it has a lipid bilayer that makes it up. Inside of that envelope is a very important genome. And that genome is actually containing something called viral RNA, right? So it's not a DNA virus, it's an RNA virus. But the important thing about that RNA is it's single-stranded. Now, when we talk about single-stranded, there's negative sense, like we talked about with, which one? Influenza. What do you think this one is? It's positive sense. So it's positive sense, single-stranded RNA virus. Now, influenza had an enzyme in it. It had the RNA-dependent kind of RNA polymerase. This one doesn't have it. It actually is interesting where it's incorporated into the gene. So whenever this gets into the cell, it's going to use that gene to make that protein. And it's actually a critical component, especially when we talk about it in the pharmacology aspect of this. What's really important to the SARS-CoV-2 virus structure is these proteins that are on the surface. There's a lot of them. I'm going to mention the less significant ones. So we're going to skip this one, but we're going to go to the other ones. And I want you to remember those just mildly ones. This is going to be, we're going to remember it via the mnemonic MEN. All right? MEN. And this is going to be, you have membrane, right? So you're going to have the membrane surface glycoproteins. It's just critical to maintaining the structure of the virus. E is an envelope protein. This is important because the envelope protein can kind of act as an ion channel. N is a nucleocapsid. So it's helping to be able to protect the RNA and kind of stabilize its overall structure. But the most important one, and you can kind of base it by the look of it, this looks like a little, I don't know, like some kind of fish hook of some sort. This is called the spike protein. So this one is extremely critical. It is the most important one, and we'll talk about why in a second. This spike protein is really the primary component of the virus that allows for it to attach to our host cells. So whenever this virus gets spewed into somebody's respiratory tract, it needs this protein to bind onto the host cells. And we'll talk about how it does that in a little bit. Now, that's the big thing I want you to know about the overall just virus name and structure. The primary virus that causes COVID-19 is the SARS-CoV-2. It's an envelope virus, viral RNA, which is inside of that, and it has a bunch of different proteins, but the most important one, which I want you guys to remember, is going to be the spike protein. This is the most critical. And the reason why it's the most critical is because it attaches to the ACE2, and on top of that, we're going to talk about things like antibodies, which we give in vaccines that are going to target that one. All right. One of the things that's happened over the years since COVID-19 is you come up with variants. There's a bunch of different types of variants, and we call them VOCs, or variants of concern. A couple of them is we started off with the alpha. All right, so we had alpha, then we had beta. And I'd say the primary two predominant ones that we've gotten to nowadays is Delta and Omicron. So these are going to be the two ones that nowadays we pretty much see these as the primary ones. This was probably the worst one, the original one, and then now we've gotten to these two, which thankfully they have the lowest overall kind of like true mortality, but we'll differentiate between these two in a second. So we start out with alpha, then beta, then delta, then Omicron. How does this happen? It's not that complicated. What did I tell you was the most important protein? The spike protein. What happens is, here is the COVID-19, the SARS-CoV-2 virus. So here's the viral RNA. In this viral RNA, it has different sequences that can code for particular proteins. Let's just pretend for a second that here is that sequence. And this is going to code for the spike protein. So what's going to happen is it's going to code for a very specific spike protein. We'll represent that spike protein right here. Here's the S, right? And that's going to then do what? It's going to be the primary protein that we talk about on the surface of the SARS-CoV-2 virus. So what's going to happen is this will be incorporated into this virus. So now what we'll do is we'll represent this on the virus. This is our COVID-19, our SARS-CoV-2 virus. Now, this is the spike protein. What happens is that this spike protein undergoes little changes. So what happens is, let's say that this is the gene that's coding for that particular spike protein. And then over time, we have small little mutations. And now, if I have a mutation, let's pretend here for a second that this gene undergoes a small little change. I'm going to change it, I'm going to add in, there's a small little mutation, right? So here we undergo some small little mutation in the gene sequence. Now, because of that, we change a little bit of the spike protein structure. If we change the spike protein structure just a little bit, what's the problem with that? Well, the virus gained the ability to have two benefits of that. One is maybe it improved the ability to bind onto and get into epithelial cells. So in other words, it increased its pathogenicity. So maybe it became more pathogenic, meaning it can actually get into the cell, it can cause more damage. And so it had an increased ability to damage host cells. So maybe increased pathogenicity, let's say. Pathogenicity. That's one component. Maybe it gained the ability for that spike protein to be able to bind onto this particular receptor, which we'll talk about on the epithelial cell. Do you guys know what that receptor is? Just if I give you guys an information about this. This is going to be, for right now, I'll tell you it. It's called the ACE2 protein. What is this one called? It's called the ACE2 protein. That is how the virus, that spike protein, binds to the epithelial cell. It needs the ACE2. Technically, what also happens is it needs a priming component here called the TMPRSS2, right? And that structure is what helps to prime the virus to get into the cell. What's happened over time is that this virus has gained the ability to maybe avoid priming mechanisms or improve its ability to get taken into this epithelial cell. So that's one downside here, is that maybe over time, especially something like Omicron, it doesn't need that. It doesn't need the priming. It can use endocytosis, bind to the ACE2 and get taken up. Another problem with small mutations in the spike protein is that you generally have plasma cells, and these plasma cells are supposed to produce antibodies. And these antibodies are supposed to be generated based upon their exposure to maybe an alpha, beta, whatever it may be. They were exposed to a different type of spike protein. You undergo a mutation in that. That mutation may not allow that antibody to bind to the spike protein and have the same immune response. And so the benefit of having this small mutation is that now when the spike protein tries to go, let's actually put it here, when it tries to go and do what? Bind onto these, it may not have that ability to bind as well. And so because of that, if this interaction doesn't occur as well, what does that lead to? It leads to an increased evasiveness. And I think that is the biggest thing that we see as a result, is that there's an increased pathogenicity, we may say, and an ability to evade our immune responses because of these small mutations that occur within the actual gene sequence that leads to small changes in the spike protein that now antibodies and our host cells allow the virus to get taken up, or they don't actually, they're not as susceptible to actually being attacked by our immune system. So why is that important? Well, since Delta and Omicron are the big ones now, Delta, we associate this one as compared to Omicron. Delta is believed to have more risk of pathogenicity, and it has more of a predilection for particular respiratory epithelium. Same thing for Omicron. This one has gained the ability to be more evasive and has a predilection for specific parts of the respiratory tract. Let me explain. So we compare this Delta versus Omicron, which are the big ones that we really want to be able to know now. Delta has increased pathogenicity, so it may cause more severe disease. Even though it's nowhere near as severe as Alpha, it still can cause more severe disease than Omicron. Omicron has less of that pathogenicity, but it's able to be more evasive. It's less pathogenic though. And so we're gonna say that this one has increased pathogenicity. So it gains the ability to do what? It allows for this one to potentially cause more damage. And this one has more evasiveness. And we could also just say in general, it's less pathogenic. All right, let's actually do that instead. Omicron, I want you guys to actually remember that more specifically. Omicron is actually going to be less pathogenic. All right, so it has decreased pathogenicity. The other component is the predilection. So which tissues of the respiratory tract do we see more damage from these two? The Delta affects more of the lower respiratory tract. Right? And so because of that, you'll see things like pneumonia more often because of that one. This one affects more of the upper respiratory tract. So because of that, you see things like upper respiratory tract infections. So that is the big difference here. Delta, more lower respiratory tract predilection. And then Omicron, more upper respiratory tract predilection. So again, taking away from this, if someone said, hey, Zach, explain the etiology of COVID-19, I'd want you to say it's due to the SARS-CoV-2 virus. If they said, what's the most important part of it? Well, it does have RNA, but the biggest thing that makes this thing dangerous is the spike protein. Why, Zach? Because the spike protein is literally the key that is going to bind onto a lock in our host cells. What kind of lock? Well, I'll get to that, but it's called ACE2. Why is that such a big deal? The reason why it's such a big deal is that these viruses, they mutate, they change a little bit of their spike protein, which makes them able to evade the immune system against those antibodies. And on top of that, maybe they gain ways of being able to cause more damage or get into our host cells a little bit easier. Now, with that being said, the next thing I need you guys to understand is anybody can get infected with the SARS-CoV-2 virus, but not every single patient develops the scary, scary disease that we see with it. And that's not just dependent upon the type of variant. It's dependent upon the individual, the host that the actual virus is going to bind to. And that's dependent upon specific risk factors. So for example, if a person became exposed to this virus, the SARS-CoV-2 virus, it got into the airway and it's got down here and it caused some damage. All right? So once this virus got down here, it has the ability to bind onto these different types of cells. What are these cells? These are called type 2 alveolar cells. And let's say here I have the virus. And again, how does it bind onto these alveolar cells or these epithelial cells in general? It uses the spike protein, which is this red structure here. Binds onto the ACE2. Then what happens? It gets taken into the cell. We'll go over that. But it's going to produce some degree of tissue damage. That tissue damage is going to alert the immune system. The immune system will then bring in inflammatory cells. What kind of cells? Well, once this tissue damage occurs, we should trigger things like a bunch of different cells. Monocytes, or what are the monocytes that are basically in the lung tissue? Alveolar macrophages. It may activate things like neutrophils. It may activate things like CD4 cells. And so you may get things like macrophages that are supposed to be activated by that tissue damage. You may get neutrophils that are activated by the tissue damage. You may get T cells and B cells that are activated by that tissue damage, right? But these cells are supposed to come in and help you to fend off that virus. They produce inflammatory cytokines, they damage the actual virus, but unfortunately sometimes they lead to tissue damage inadvertently. But this is supposed to go and activate these macrophages. We want them to activate the macrophages. We want them to activate the neutrophils. We want it to activate these cells so they can come in and generate an immune response. My question to you is these will come in and help to generate that immune response, but what if a person doesn't have that proper immune response? And so what happens is these cytokines come into play, but this response is lost. And so I lose this ability. So now I'm supposed to be doing this, and instead I don't have the macrophage response. I don't have the neutrophil response. I don't have the T cell response for some reason. Because of that, now this virus can keep causing tissue damage without any ability of me being able to stop it. That's when this infection can get much worse. I'll end up with more tissue damage. As a result of more tissue damage, I end up with more lung disease. With more lung disease, I end up with a worse overall clinical scenario. So the thing I want you to remember is this is supposed to be the we'll represent this as the cytokines. The cytokines are supposed to activate your immune system, right? That's what the cytokines are doing. But if I don't have the immune response, this tissue damage will continue to occur. And with that lung damage, what's going to happen? Eventually, the worry here is that it can progress to pneumonia, it can progress to ARDS, and we can get a pretty sick patient. And this is really oversimplifying it, but we'll go into more detail a little bit later. Patients who have a reduced immune response, they're at higher risk for things like pneumonia, ARDS, because they don't have the immune response. What kind of conditions would that be? That'd be anybody who is immunosuppressed of any sort. I mean, it doesn't take a genius to think that someone who has HIV, AIDS, they're on some type of medication, TNF inhibitors, steroids, they are transplant rejection meds, you get the point. Pregnancy is also a really big one. So pregnancy it's kind of multifactorial. It's not just an immune response. They do have reduced T cell activity, but also they have other problems because of their overall, I don't know how else to say it, the overall morphology of being pregnant and it kind of pushing the diaphragm up and create more of a restrictive physiology. So there's a couple different components to that. And the other one, probably the biggest risk factor for developing severe COVID-19 is older age. And we kind of define that by greater than 65 years. This is just because they're becoming more immunosenescent. Their immune system cells are just more kind of like, bro, I'm tired, you know? So pregnancy can decrease their T cell function. Immunosuppressed patients, they may have reduced overall immune system activity in general. And older age, just kind of like some fatigued out, tired immune system cells. Either way, because of that, that can lead to severe disease. And that's the patients we got to be careful for. Comorbidities, what this really does is if a patient gets this disease, let's pretend for a second. Let's say you have a patient who has COPD. So they have they have kind of an overall obstructive airway disease. So because of that, you bring in this virus, and this virus produces tissue damage. That patient who already has a reduced pulmonary reserve can worsen their underlying lung disease. And so what could happen is if this virus gets in, it could worsen their lung disease. So it could worsen lung disease. So think about that for a second. If I have a patient who has COPD and I get a virus in there, this is the same thing. This is why we really support influenza vaccination in COPDers. We support COVID-19 vaccination in COPDers. Why? Because it can precipitate exacerbations. The other thing that's really interesting here is diseases like diabetes, CKD, obesity, like morbid obesity, CHF. We can go down the line. These are all chronic diseases. And probably to some degree, these diseases create some form of inflammation or endothelial dysfunction. So at baseline, here's what I want you to remember, is these probably have a baseline, higher degree of inflammation than the normal individual. So their inflammation levels are probably just a little bit higher, and on top of that, they probably have some degree, especially CHFers, diabetes, CKD, they probably naturally have some degree of endothelial dysfunction or some form of cardiovascular disease, all right? That's probably just a normal thing, is they probably have baseline, increased inflammation, and probably endothelial dysfunction. Here's what's interesting about COVID-19. It prefers the epithelial cells of the respiratory tract, but it also has, look what I have here on the vessel. On my blood vessel, on the endothelial cells, there's ACE2 receptors. And so if this virus has the ability to get out here and bind onto these ACE2 receptors, it can get taken to the endothelial cells and produce endothelial dysfunction. And if I produce endothelial dysfunction, and on top of that, this disease worsens cytokine storm. So whenever you get inflammation of the lung tissue, cytokines get poured out. So the other component here is that they also get lots of cytokines. There's going to be immune system cells that'll come in here and they'll help to generate an immune response, and they'll start pumping out lots of cytokines. So you get two things. We get lots of cytokines and you get endothelial dysfunction. The combination of these two things can promote severe disease. So then what I mean is I could get things like thrombosis. I could see things like ARDS. And so because of that, that is going to put all of these patients at high risk of things like thrombosis, ARDS, etc. So you get the point, these patients are very, very high risk for what? Not just having COVID-19, the worst case of COVID-19. Either you don't got the immune response to fight them off before it gets bad, or you have the immune system, but you got so many comorbidities that put you at risk of exacerbation of your underlying disease, and you just don't got the reserve to deal with it. Or you have a disease that has baseline problems with the vascular system and inflammation. You add more inflammation, you add more endothelial dysfunction, you tip them overboard into a lot of different problems. That's the key thing I want you to take away from that. All right. So far, Zach has said what? COVID-19 is due to SARS-CoV-2 virus. The most important protein is the spike protein. Why? It's the key that accesses the lock to our epithelial cells of the respiratory tract. By what? ACE2. Why is that such an important thing? Because as viruses start to mutate, they change their spike protein to evade the immune system, or monoclonal antibodies. And on top of that, they also gain other ways to get into host cells without having to use the host cell's machinery, which makes it dangerous. The other component here is that anybody can get kind of a SARS-CoV-2 infection. The question is more important is who is at risk of the severe one that can kill them? If I get a cold, if I get an upper respiratory tract infection, that is important, but it's not as important as, and it wouldn't be as concerning to me as something like, oh, I got pneumonia, or I'm gonna have ARDS, or I can actually get multiple clots in my body, or I could end up dying. That's really important for me to know. The patients who have an impaired immune response are comorbidities that could worsen their underlying lung disease, or diseases that have baseline cardiovascular dysfunction, and we add on COVID-19 to that, it can increase the risk of severe disease. What I need to do now is I actually want to talk about this from the moment the respiratory droplets. So here you have patient 0. They sneeze, they cough, they aerosolize this virus. This virus is then transmitted via that respiratory droplets into the patient's respiratory tract. All right, so what is the way that this gets transmitted? The route of transmission is called, we say it's just via respiratory droplets. That's how the virus gets from point A to point B to cause the underlying infection. Once it gets to the respiratory tract, it can affect the upper respiratory tract, it can affect the lower respiratory tract. Again, depends upon the virus, depends upon the patient. We're not gonna get into that detail, but let's pretend that we zoom in here and we say, okay, how does the virus actually access the cell? You're probably like, Zach, dude, do I really need to know this? If you wanna understand the pharmacology, I think it's important. So here we have the virus. What did I tell you is the most important protein on that virus? The spike protein. I know you all said it. Here's my spike protein. The spike protein is going to bind onto this receptor. That is the lock. What is the lock? Again, we have our spike protein. I'll write it out here. Here's the spike protein. So the first thing that we need is we need this virus to stick to the epithelial cell. So it uses the spike protein. Sometimes it's even called the S protein, just so that we're aware. And it binds to something called ACE2. We already know this. That's on the host cell. This is just an epithelial cell of the upper or lower respiratory tract. This is the first connection. Now, technically, the spike protein has 2 subunits. The part that binds to the ACE2 is called the S1 subunit, all right, or the receptor binding domain. And then there's another portion. The S2 subunit is really, and this changes a lot with Omicron. I'll explain what I mean in a second, but there is this spike protein that binds with the ACE2. And this portion here that's binding to the ACE2, this like little curly portion right here, that's called the S1 subunit. This portion up here, let's just call that the S2 subunit, like the little strand or the little stem that's holding this S up. Let's call that, so let's say here is your S1 subunit. Here is your S2 subunit right there. All right, here's S1, here's S2. There's a protein on the host cells called TMPRSS2. SS2. This is basically a special kind of enzyme that is supposed to do what? Well, we want this virus to really fuse. We want it to kind of stick with this receptor and get taken in. So what happens is this TMPRSS22 helps with the fusion process. So it basically kind of helps to cut the S2 subunit and allow this whole thing to fuse with the cell membrane. So now, because of that, let's actually bring this over here for an example. Let's say what will that look like? So it goes first thing, binding of S1 of the spike protein to S2. Then from here, S2 is still sticking to it, but we got to get this whole thing to fuse. TMPRSS22 does what? Acts on the S2 protein, cleaves it so that they can fuse. Then once that happens, now my virus, that was loud, sorry, is gonna be like this. Do you see how it fused? So this is the third part here, which is called fusion. And that fusion is really the critical thing. So we have first thing is the attachment, which is going to be S1 subunit of the spike protein to ACE2. Then we need to prime it. So this is the fusion part. This is what's called the priming. This is the priming portion if you really want to write that out. Here's the fusion. The binding. Let's actually call that particularly. Let's call this the binding component. So 1 is binding, 2 is priming, 3 is we're going to fuse this bad boy. All right? Once it fuses and it's really, really nice like this, now we have all of the genome, the viral RNA, that can do what? It can get pushed right into this epithelial cell. So now this viral RNA can then uncoat and release that viral RNA right into the host cell where it can start doing all of its bad stuff. And that's that positive strand, single-stranded RNA. That's that part right there where it's kind of releasing the RNA into the cell. That's the uncoating process. Why am I mentioning all of this? The reason why I'm mentioning this, and I promise we'll get into this into the treatment part, but what if I had a way of blocking that spike protein from even sticking to the ACE2 and going through all of this to get into the cell? That's where drugs like vaccines or monoclonal antibodies come into play to block that step. That's why. So that's the clinical significance I want you guys to think about here, is this is where we can bring in monoclonal antibodies, which we can either give to the individual like Pemgarda, or we can give vaccines to help them to generate the monoclonal antibodies against that spike protein. That's why I'm taking the time to talk about that. All right, once we've gone from that stage, this thing is now at the point where it's going to release the virus, the viral RNA, into the cell. Once it does that, the first thing that's going to happen is this viral RNA is going to go to ribosomes. When it goes to the ribosomes will then take that viral RNA, that single-stranded RNA, translate it and make proteins. The key thing here, and I'm just going to make a big, let's just say I make a big glob of it. Here's going to be a protein here. And I'll do it in different colors just so you guys get the point. There's going to be this component of the protein here. And then we'll do another component of it. We'll just do this part in purple. But this we're going to call a polyprotein. So this big structure that the RNA undergoes translation makes a polyprotein. This polyprotein has a bunch of different things that I need in order to make more viruses. All right, so this is called your polyprotein. What I need to do is I need to cleave or break up, eat this polyprotein into small individual pieces. So that's all I want to do, is I want to take this polyprotein and I want to break it up into a bunch of small different types of proteins. I'll represent maybe like a couple dots here. There's like a little protein. Again, here in purple, there's a couple different proteins. And then here in red, here's a couple different proteins. But I need these. If I don't get it cleaved out of that polyprotein, I can't make new viruses, theoretically, right? So I need somebody to come in and eat this thing up, all right? You'll never guess the name of this one. It's called a protease. Now there is very specific types, but for right now, I just want you to remember it is called a protease enzyme. The protease enzyme is what's responsible for eating that polyprotein up and generating all of these different types of proteins. We'll call them, for right now, let's call them non-structural proteins. All right, so technically what we'll call these is non-structural proteins. This is not your spike protein, your envelope protein, your membrane protein, your nucleocapsid. They're very specific in their activity. One of these And I'm actually gonna draw this in orange now too. Let me actually add a little piece on just so I can be very, very specific. I'm gonna add like a little orange piece in here, all right? There's a very specific enzyme that's formed whenever we break these polyproteins up. And this is the one in orange. This one is actually a very weird looking one. It's called RNA-dependent RNA polymerase, which we're gonna put as RDRP, RNA-dependent RNA polymerase. What this does is, that viral RNA that comes in, this dude can read it and make copies of it, and then on top of that, it can read the viral RNA and make mRNA. That's pretty interesting. So now what we're gonna do is we're gonna take this viral RNA, we're gonna have it go over to this dude, and he's going to do what? Well, he's gonna do two things. One is he's gonna make a bunch of copies of that viral RNA. So let me just draw a couple of these copies. So here I have a copy here I have a copy here, but I'm making a bunch of copies. That's one thing. The second thing I'm gonna do is I'm also going to make mRNA. So one thing is I'm gonna make copies, that's called replication. The other thing I'm gonna do is I'm going to allow for me to make very specific mRNA, all right? From this mRNA, this is gonna go over to the rough endoplasmic reticulum, where I have a bunch of ribosomes studded on the surface, all right? Whenever this mRNA goes to this rough endoplasmic reticulum, where the ribosomes are studded all over the surface, I'm gonna use that mRNA to translate it and make very specific types of proteins. Now we need to be very, very particular. So from here, we're gonna push these proteins in. And what are these different proteins? These are those structural proteins. So let's actually go back. What was the particular proteins on the surface? Well, the big one is the spike protein. That's one. What was another one? It was, what color did we have this one? Blue, that was the membrane protein. So we'll draw here, we have a membrane protein. And then we have another one, green, envelope protein. But there's one that we do not make here. It's called the nucleocapsid protein. We don't make that one here. It's actually made over here. So technically, RNA-dependent RNA polymerase will actually use the mRNAs and make very specific proteins to bring that one over here. And we represented that one in this pinkish color. So that's actually made by cytosolic ribosomes, not the rough ER. And again, it gets into a little bit of a weeds here, so I don't want to go too crazy. But what happens is, from here, the spike protein, the membrane protein, the envelope protein, all of these are formed here, and then guess what happens? They get kind of pushed into the membrane of the rough ER. When it gets pushed into the membrane of the rough ER, then what happens is this buds off. And when it buds off, look, son of a gun, this buds off here, and now it's got all these proteins studded on the surface, right? Which ones? Well, we got the envelope protein studded on the surface. What else? The most important Mac Daddy one, which is our spike protein. And what was the other one? The membrane protein. These are all studded onto the surface. We almost have the virus though. So right here is our kind of our lipid bilayer, which is almost like the envelope. And we have some of the surface glycoproteins. RNA-dependent RNA polymerase already made a bunch of copies with the nucleocapsid proteins. Guess what happens? Eventually, we'll talk about this in just a second, but these two will meet up at a very specific destination. And then we're gonna start assembling all of this. Zach, why do I need to know all of this? When we have patients who have very severe COVID-19, we utilize drugs to inhibit the protease. If I inhibit proteases, can I break down polyproteins? Can I make all of these different things that I need in order for all of this process to occur? No. And so all this viral replication and proteins that I need to make the virus stops. What if I had another drug, which I inhibited the RNA-dependent RNA polymerase? I wouldn't be able to do all of these processes where I make new viral RNA or I make mRNA to make new viral proteins. So this is where drugs, which we'll talk about a little bit later, called Paxlovid, nirmatrelvir, and ritonavir come into play to inhibit the protease. And then remdesivir inhibits RNA-dependent RNA polymerase. Again, that's the significance of that. Now, at this point, This COVID, man, it's using our cells to be able to do a lot of stuff. We already said, just as a recap, RNA-dependent RNA polymerase is copying. It's undergoing replication. It's making mRNA. The mRNA is then actually helping to make structural proteins. These structural proteins are then being incorporated into a vesicle from the rough endoplasmic reticulum. These two things, all the viral RNA and this vesicle from the rough endoplasmic reticulum, meet at what? The Golgi. And when they meet at the Golgi is going to package all these puppies together. And then now we're going to have our final thing that we need to really get this virus assembled and then to piece out. In this membrane-bound vesicle, we'll have all of the particular proteins. Again, just to recap it, we'll have our spike protein, we'll have the membrane protein, we'll have the envelope protein, we'll have the nucleocapsid protein, and then inside is going to be tons and tons and tons of copies of the viral RNA. We've made it, my friends. Then what happens is, this is going to move up, and it's going to say, yo, membrane, I'm going to need you. I'm going to fuse with you, but you're going to give me another envelope. And then what happens is this thing fuses with the actual membrane, and via the process of exocytosis, we then pop this virus out. So that's the exocytosis process. Now from here, what's the downside of that? We made a new virus to go ahead and spread to other different cells. And on top of that, whenever this happens inside of this cell, it produces a cytopathic effect. So not only are you causing you're not only causing cell injury, you're also making new viruses to go and further cause more cell injury. Is there any particular thing that we can use at this stage? No. But what I want you to know is once this happens, what's the end result out of this? Two things. This is going to result in cell destruction and further spread. And at this point, we're having problems, right? So we're going to get cell injury and spread of the virus. So if theoretically we could target this thing very early at the attachment site, we could utilize ways of not allowing that virus to actually spread via different things like N95s and isolation, or we can give drugs that block these. We won't have to worry about that stage. But if it happens here, we already got cell injury and we got the spread of the virus. Now, once this happens and we've damaged the cell, we're going to have a response. This is pretty straightforward. I don't want to go too crazy, but again, I'm using the epithelial cells here, the type 2 pneumocytes. Once this thing binds, it's going to use all of that to make more viruses and replicate, and it's going to go through that cell lysis. That's going to cause cell injury. That cell injury, I already kind of talked about this. What do these cells do? Well, they release things like damage-associated molecular patterns, DAMPs. The DAMPs then go and activate your immune system. When you activate the immune system, the biggest response initially is from what? Your alveolar macrophages. When you activate the alveolar macrophages, they're going to say, all right, bro, I'm going to come on over here and check out what's going on. So these DAMPs come over here and activate the alveolar macrophages. These say, all right, let me come on over here, and they can go via the pores of Kohn and come into this area. When they do that, the alveolar macrophages are kind of like your little alarm system. They'll try to start eating up some of the viruses. But one of the things that they do is they say, I'm not going to be enough for this job. And they release a bunch of different cytokines into the bloodstream, right? So these cytokines get pumped into the bloodstream. Things like interleukin 1, interleukin 6, TNF alpha. Now, in normal individuals, shouldn't be like too bad, but they're going to pump some of these cytokines out, and that's going to go and alert your immune system. It's going to bring in more macrophages, more monocytes, right? So what this should do is bring in more monocytes, bring in some neutrophils, because it even releases things like interleukin 8, which neutrophils love. And then on top of that, lymphocytes. So I'm going to activate all of these different types of cells, bring them to the area. It's pretty much going to be these two first, though. So let's get rid of the lymphocytes. We're going to bring these two primary ones to the actual area of injury. And we're going to trigger a response. Macrophages will undergo phagocytosis, neutrophils will actually release proteases and reactive oxygen species, things of that nature, and it even undergoes phagocytosis. But these are going to come and try to cause, they're going to try to clear the virus. But unfortunately, when they attempt to try to clear the virus, sometimes these guys, especially the neutrophils, they can cause tissue damage as kind of an overall bystander effect. It releases things like reactive oxygen species, proteases, etc. So that's our first response, the innate response. And this is going to just cause an inflammatory reaction. Depending upon where it occurs, that's going to cause the overall symptom. If it occurs in the upper respiratory tract, they'll have upper respiratory tract symptoms. If it occurs in the lower respiratory tract, they'll have the pneumonia-like symptoms. If it occurs in the body, you'll have the appropriate organ tissue effect there. The adaptive response is also really critical. When this virus gets down into the alveoli, again, this is the most concerning area if it can get into, and it damages these type 2 alveolar cells. When you damage the type 2 alveolar cells, we already said that that's going to cause those damage-associated molecular peptides, right? But what we did say is that those damage-associated molecular peptides, let's get rid of this blue marker, it sucks. It's going to do what? It's going to tell your, oh, that's good stuff right there. That's going to tell your alveolar macrophages. Alveolar macrophages are going to release all of those cytokines. What were those cytokines again that we talked about? We just talked about it. Come on, guys. Here it is. It is interleukin 1, interleukin 6, TNF alpha. That's going to bring in a bunch of different immune system cells. When these immune system cells get to the area, especially things like macrophages, more macrophages or monocytes and dendritic cells, these are called antigen-presenting cells. APCs, bruh. When they come into the area, they're going to undergo phagocytosis of the virus. So they'll take this virus that's all going to be out here in these purple dots I'm going to represent it as, and it's going to undergo phagocytosis. When it undergoes phagocytosis, it's going to bring it inside and express it on its surface. So it undergoes phagocytosis, and then it undergoes antigen expression. So it's going to express a very specific piece of the virus on its surface. What's the very, very important one? It's the S protein. And it's going to present it on its MHC2 complex. So it presents it on its MHC2 and presents that on its surface to the T cell receptor that's present on the T cell. Based upon this interaction, when this occurs, the T cell becomes activated. When that T cell becomes activated, it does two things. It releases cytokines that push B cells to become plasma cells, and it also helps to form different types of other T cells. Maybe it forms memory T cells and cytotoxic T cells, but it's going to help to form different types of memory T cells are going to be formed. And on top of that, it's going to cause a B cell to become a plasma cell, and that plasma cell, as a result, whenever it releases the very specific cytokines to make more memory T cells or to stimulate the formation of plasma cells, these plasma cells will now make antibodies. And these antibodies are going to be just perfect to be able to bind onto what specific protein that's present on the viral surface. Come on, I know you guys know this. What is it? It's going to be the spike protein. This is a way that we should have a normal immune response. So if you think about this, you get infected with the virus. If you have a person who doesn't have the appropriate immune response, are you going to be able to generate antibodies? Are you going to be able to fight this virus off? No, and this is why this virus can keep replicating and replicating, causing further damage without a proper immune response. It's going to cause the patient to get really, really sick. All right? Now, this is kind of how things should be happening, and this is kind of a normal inflammatory response. But what I really want you guys to take away from this is whenever that SARS-CoV-2 virus attaches onto these different cells, it uses the ACE2 receptor. That was the common theme. These ACE2 receptors are present all over the dang place. The primary targets is the upper respiratory tract and the lower respiratory tract. Think about this for a second. It's very, very straightforward. It's not that hard to imagine. If I attack the upper respiratory tract, what kind of symptomatology should I be concerned about? Well, if it's upper respiratory tract versus the lower respiratory tract, the upper respiratory tract, I would be worried about upper respiratory tract infections. What does that look like? I'm talking about a person who has rhinosinusitis, nasal congestion, nasal discharge. Maybe they have a headache, maybe they have facial pain and pressure. Maybe it's affecting the throat, so they have a sore throat. On top of that, maybe they even have a little bit of postnasal drip that's causing a cough. They have a low-grade fever, right? If it's lower respiratory tract, we're talking about things like the concerning feature like pneumonia, right? They have cough, dyspnea, tachypnea, increased work of breathing, fever. These are the concerning features, right? A secondary target, again, that has lots of those ACE2 receptors, I already told you, is the endothelium. So another really important part here that also has lots of those ACE2 receptors. So because those viruses bind onto these cells, they'll produce replication and damage those cells. What can that result in? If I damage that, I can lead to endothelial dysfunction. Whenever you have a damaged or dysfunctional endothelium, my friends, why is that really important? The endothelium is supposed to make things like prostaglandin, I2, nitric oxide, prevent platelets from sticking. It also is supposed to kind of shield von Willebrand factor. If those things are all happening, von Willebrand factor is exposed, I can't make those antithrombotic things, what's going to happen? I can get clots. And that's the concept of what we call Vircho's triad, right? And so that's another big thing here. All right, endothelial dysfunction can lead to thrombosis. And that thrombosis component is what really scares us with this disease. And that can be direct damage from the virus, and it can also, we'll talk about a little bit later, due to cytokine storm. Other targets, there's lots of ACE2 receptors that are present on the enterocytes. If it's present on the enterocytes, what kind of thing could happen? These are supposed to be involved with absorption. So what could I potentially see? I can see abdominal pain and diarrhea. All right, so diarrhea may be a potential thing that can happen if it's affecting the GIT, right? The enterocytes of the GIT. It also can affect the myocardium. So what could I see as a result of this? Myocarditis. Myocarditis, dude, this thing can cause what? Potentially cause acute heart failure. Sorry, Rob's over here screaming at me to put 2 R's in here.
That's right.
Diarrhea. So GIT, the enterocytes are getting damaged. The myocardial cells are also getting damaged, and that's causing myocarditis. Now, this is why we can see potentially things like diarrhea and even like abdominal pain with this disease. Now, myocarditis is pretty scary. And if you get an inflammation of the myocardium, that could lead to a lot of different problems. You could end up with, it can cause acute heart failure. That's probably the most concerning feature. So if a patient came in with acute heart failure, sometimes it can cause ST changes as well. The other thing that we get worried about with myocarditis is arrhythmias. Now, the other thing is on the kidney, the proximal tubular cells, there is also lots of ACE2. And so the kidneys, especially the proximal tubular cells, have a heavy amount of that. And that can lead to something called acute tubular necrosis, which can precipitate something called a AKI. And AKI is mainly going to present with things like a bump in the creatinine, potentially less urine output, called oliguria. And so these are all possibilities of the virus's intrinsic ability to damage these cells by what? By binding. That does this by binding what particular thing? I need you guys to remember this. Binding the ACE2. If it binds onto it, it can cause it to replicate and damage the cell. If it damages the cell, you can get all of these potential effects. And then on top of that, if that's the base effect and then you add something onto that like cytokine storm and other individuals who have very high risk factors of getting really, really bad, that's when we see the severe cases like really bad myocarditis, really bad kidney injury, really bad pneumonia, really bad clots. So that's the key critical thing that I want you guys to take away. There's also one other thing, it's kind of a part of the upper respiratory tract. And that's what makes this kind of like, it's kind of like a unique thing to COVID. There is a olfactory epithelium right here. And there's also, within our tongue, there's a gustatory epithelium, all right? Let's represent it in green, a little gustatory epithelium. If the virus has ACE2 receptors on those epithelial cells, binds onto it and damages them, unique types of symptoms that can result as of the damage of the olfactory epithelium is called anosmia. All right? And then damage to the gustatory epithelium is called aguesia.
No, I knew you spelled it wrong. That one you're not getting. It's okay. You spell it wrong every time in your Google Doc. I'm sorry.
Okay, what is it?
Spell out the word age and then guesia. So the word age, A-G-E.
Okay.
G-U-S-I. So age, guesia. I don't know how I'm going to say that.
U-I-S-A?
Yeah, G-U.
Okay.
G-U-S-I-A.
G-U-I-S-A.
No.
Oh.
Here, let me just make sure. I correct it every time in the Google Doc because I'm like, it's so weird that sometimes it mixes.
All right, so A-G-E.
Yeah, you spell age and then almost like USA, but U-S-I-A.
Okay. Okay. Gotcha.
Let me just make sure. Age, U-S-I-A.
Okay.
Usia.
All right, gotcha.
Okay.
All right, so if we damage this gustatory epithelium, it's going to lead to a decrease in taste. So this is a decrease in smell or absence of smell. This is going to be a decrease or absence of taste. And this is called aguesia. All right? I like to say aguesia. Either way, this is the unique components where if you see something like this, not a lot of viruses or infections cause this type of presentation. So again, it can have multiple different targets. The primary ones is the epithelial cells of the upper respiratory tract, like your goblet cells, your pseudostratified ciliated columnar, and then again, the lower respiratory tract, the type 2 pneumocytes. All right? But again, you can see this all over the place. All right, so at this point, we've really gone in, just as a quick recap up to this point, SARS-CoV-2 is the virus. Spike protein is the most important one. It's an RNA virus. Again, risk factors that are important for the progression to severe disease is those who have immunocompromised states, age greater than 65, pregnancy, which is kind of a multifactorial feature, comorbidities that can either exacerbate their underlying disease or make that ARDS possibility, thrombosis possibility, more likely. We talked about how the virus is transmitted via respiratory droplets. Once it gets into the airway, it binds onto epithelial cells via the ACE2 and the spike protein connection. Sometimes you need priming. Once it gets into the cell, uses enzymes to replicate all of the viral RNA and make more proteins, assembles it, pops out of that cell, damages the cell, goes and spreads to other cells. We get an innate immune response, which should normally occur with macrophages and neutrophils. We get an adaptive response. Our body's supposed to produce antibodies and generate memory cells, T cells and B cells. And then on top of that, once these viruses attack these different tissues, it's going to cause cell damage. If it's of the upper respiratory tract infection, lower respiratory tract pneumonia, endothelial cells, you can get thrombosis. All these other different tissue cells can have direct cytotoxicity. The big thing that I also want you to take away from this is we can have most patients live with that primarily upper respiratory tract infection like presentation. Some can get that pneumonia presentation. Some can have other organs being affected. What I really want to understand is how does that direct cytotoxicity translate into a way worse, way more severe disease? It's not just now the damage from the virus. It's two other mechanisms that make it much worse. So one of them is related to angiotensin 2. Normally, you have this, that's ACE2. Normally what happens is angiotensin 2 is supposed to be acted on by ACE2 and converted into angiotensin 1,7, all right? Angiotensin 1,7. This is a normal reaction, and angiotensin 2 is supposed to be acted on by ACE and converted into this, right? Angiotensin 1,7 is kind of like, it's nice because this one is not really a pro-inflammatory type of molecule. Angiotensin 2 is. When a person infected with that SARS-CoV-2, they have that spike protein. The spike protein will bind with the ACE2. And what happens is once that happens, you get fusion. When you get fusion, what happens to the ACE2 level? So once you have this fusion reaction that occurs between the spike protein and the ACE2, what ends up resulting is that this ACE2 levels that get taken inside the cell, they get downregulated. So then what happens is I have a reduction in the ACE2 levels. That means that this reaction is not going to occur. That means I don't make as much of the angiotensin 1,7, and instead I end up with a buildup of angiotensin 2. If that happens, the problem with this then is what's really interesting. Angiotensin 2 is kind of like it's an inflammatory molecule. One of the things that it can do is it can act on our pulmonary vasculature, and it can do two things. One is it can cause the pulmonary arterioles to undergo an intense vasoconstrictive mechanism. So now this vessel is going to clamp down. Ooh, baby, that ain't good. All right, so that's the first thing, is we're going to undergo pulmonary vasoconstriction. So the first thing is pulmonary vasoconstriction. Now think about why that's important. If you have pulmonary vasoconstriction, this is going to be really difficult to bring oxygen, or actually bring blood, I'd just say. Just bring blood, which is rich in CO2, and then undergo gas exchange, which will then move the oxygen through here. That blood flow is going to be affected. And so what's going to end up happening is you may have a reduction in that perfusion concept there. And that reduction in perfusion may lead to a VQ mismatch. And that can worsen a patient's lung function, right? They can end up with a kind of an acute lung injury at this point. This pulmonary vasoconstriction, when it kind of reduces that perfusion by clamping down, you cause VQ mismatch. On top of that, it also can cause the pressure inside of the pulmonary circulation to go up. So think about this. If it's really hard to squeeze blood through there, right, then what's going to happen is you're going to end up with a back pressure. And as a result, if I have a back pressure, all the pressure built up prior to this little vasoconstrictive point is going to trigger pulmonary hypertension, and that can put a lot of strain onto that right heart, right? So two things can happen as a result of this: a back pressure causing pulmonary hypertension and reduced perfusion, which can cause VQ mismatching. The other thing that it will do is it'll make the pulmonary arterioles super leaky. And now, if I increase this capillary leakage, now not only do I vasoconstrict, affecting the perfusion, but guess what else I do? Any plasma that's running through here is going to leak out. And it's going to leak into the interstitial spaces. It's going to leak into the alveoli. And if I start filling up this alveoli, that's going to be a particular problem. So then what's up happening is I end up with alveolar consolidation. Alveolar, and we can just call this like filling if you want, but we'll just, for right now, we'll call this a consolidation. The combination of this, the pulmonary vasoconstriction and the capillary leakage effect, is what leads to acute lung injury in these patients. So all this does is these two things lead to acute lung injury. And this is what's going to make a patient be more likely to progress to ARDS, to develop a severe case of pneumonia. So that's one concept. One of the concepts that's really, really critical here is that we think that the virus, we know it's downregulating ACE2, increasing angiotensin levels, which are causing pulmonary vasoconstriction and increased capillary leakage, which are contributing to a worsening of their lung function via an acute lung injury, alveolar filling, and VQ mismatching. That's going to increase the risk of this patient developing a severe case, such as ARDS. And that's what we get worried about, is the end result. Is this pushes a patient's risk of developing ARDS to be a little bit higher. All right? Now, that's one concept. The other thing about angiotensin 2 is it's not just, if I really wanted to keep going, this is the two big things, but we've also seen that angiotensin 2 can cause lung fibrosis. So if you really wanted to add that on there, you can even add a little bit more. I'm just gonna say it's a plus or minus if you'd like to remember it. 1, pulmonary vasoconstriction. 2 is the capillary leakage. And the third thing is it can cause lung fibrosis, which can end up making the disease just overall a little bit worse. All right? All right. That's the big things I want you guys to take away from the angiotensin II accumulation. What about the cytokine storm? This is by far the most important thing. Normal individuals, when they get that virus, if it gets into the airway, it causes damage to the type 2 pneumocytes. Type 2 pneumocytes, when they're damaged, they have less surfactant. That's a big problem. So one thing that happens is you get damage to the type 2 pneumocytes. So whenever you get damage to the type 2 pneumocytes, two things happen. One is damage to the type 2 alveolar cells, or the pneumocytes. And that results in one concept here. One is it results in a decrease in surfactant production. Surfactant is supposed to reduce surface tension, which is the alveoli wanting to assume the smallest size possible. If I don't have that ability to make surfactant to reduce surface tension, what happens? The alveoli want to collapse. And that's a pretty stinking big deal. All right, so this triggers alveolar collapse. So that's one problem. The other thing is, once this is damaged, they release damage-associated molecular peptides, a bunch of different types of cytokines, and all of this is supposed to do what? Activate your immune system. Activate your macrophages, your neutrophils, you'll bring in T cells, all of that stuff that I talked about. Normally, these cells are pumping out something called interleukin. So here's what happens. These are supposed to, I'm going to go up so I don't get in the way of this whole arrow process. But these are supposed to go here and supposed to go here. And they're going to activate things like your macrophages, activate things like your T cells, and these are supposed to pump out what? Cytokines. What are those cytokines that they pump out? I told you guys this. Interleukin 1, tumor necrotic factor alpha, interleukin 6, and even interleukin 8. But these are going to be the most significant ones. And out of all of these, probably the most important one is going to be interleukin 6. Now, in normal individuals, they shouldn't be producing crazy high levels. But in individuals who have things like diabetes, CKD, obesity, they have impaired immune responses where they're not able to fight this thing off, and what happens is you just get a very bad cytokine storm. These things are in super high levels. Like I'm talking super high levels. Because of that, they get a more amplified immune response than most individuals. And why is that important? Well, one is we already have the alveolar collapse. These cytokines are going to come here to the lungs, and what they're going to do is they're going to make these capillaries, they're going to make the vessels dilate a little bit, but they're also going to make them super leaky. If they get super leaky, what's going to happen? The alveoli are going to fill with a bunch of fluid. So now I have the alveoli filling up with a bunch of fluid. And now I have alveolar filling. And on top of that, that was the one component. Alveolar filling is right here. What was this one? That was due to the decreased surfactant. Guess what? These cytokines cause lots of fluid to leak in, and that washes the surfactant levels even more. So not only do you get decreased surfactant from type 2 damage, but having fluid come into the alveoli washes or dilutes the surfactant. That makes the surface tension go up even more, and you get alveolar collapse. So we have a combination of these things, right? So two things are happening. But here's the big difference. These cytokines aren't just going to be released in a localized area like right here. It's going to be all over the lung. Because of that, I'm going to have damage here, 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 here. You guys get the point. I won't be super annoying, but it is all over the place. And all these red X's indicate is these are areas of alveolar filling and alveolar collapse all throughout the lung. This, my friends, is what we refer to as ARDS. Acute respiratory distress syndrome that is due to alveolar filling and alveolar collapse. How will this patient present? If I haven't told you guys this enough, you guys should know it by now. I don't need to write this dang thing down. What's happening is the patient will have multiple areas of where they can't have gas exchange. Because of that, the primary manifestation will be hypoxemia, right? A low SpO2, a low PaO2, and respiratory distress, tachypnea, dyspnea, increased work of breathing. That is going to be the big thing that we see here. All right, so that's one effect. One of the effects of this cytokine storm is I have damage to the type 2 alveolar cells that we talked about over here. And then on top of that, I got the cytokine storm that just makes everything worse. That's what leads to diffuse alveolar damage and ARDS. Another thing here is these cytokines, they have a lot of, especially interleukin 6, they have little receptors on the liver. And whenever it acts on the liver will respond by producing a bunch of different things. Some of these aren't super important, but some of them could be. One is it produces a lot of acute phase reactant proteins. One is called CRP. The other one is it can release something called ferritin. But there's another one that is really important. And this one is called fibrinogen. And fibrinogen, we know, is really important in the coagulation cascade. So we have fibrinogen, we have ferritin, we have CRP, and even ESR it's a result of having a lot of proteins. But what you'll notice about these is that patients who have these heavy cytokine storm, they'll have these high levels of these acute phase reactant proteins. And these are things that you can measure to determine, hey, there's lots of inflammation, there could be a cytokine storm brewing in this patient. But here's another component. I told you what was expressed on these endothelial cells. I represented it in pink. What was actually expressed on these cells? The ACE2. So if the virus, which we represented here in purple, binds to this endothelial cell via what protein here? The spike protein. What's it going to do? It's going to cause damage. So now there's endothelial injury. Whenever there is endothelial injury, that leads to a couple different things. So there's a couple things that result out of this. So here's the virus, right? Here's our SARS-CoV-2 virus. Binds with the ACE2 on the endothelium. That results in endothelial injury. And a couple things result as of that. One is I damage the cells. What do I expose? Von Willebrand factor. So now I'm exposing von Willebrand factor. So there results in increased von Willebrand factor exposure. The other thing is, normally these endothelial cells are supposed to release what kind of things? PGI2, nitric oxide, but it's releasing that when they're normal. It's damaged. What's going to happen? Am I going to be able to produce PGI2, produce prostacyclin? No. So if this is damaged, I can't do this. And these levels drop. So now I have exposure to von Willebrand factor, antithrombotic molecules are released. So are not released. So we have decreased PGI2 and nitric oxide. And there's one more thing. Whenever you have tissue damage to a vessel, the vessel responds by pumping out a very specific molecule. Do you guys remember what that is? Tissue factor. So there's another molecule called tissue factor. This is also known as factor 3. These levels go up because it's a vessel injury. If there's endothelial dysfunction, the vessel is injured. And so tissue factor levels go up. So the fourth thing is we also have increased levels of tissue factor. The problem with all of this, my friends, is absolutely catastrophic. I have endothelial injury, so I'm exposing von Willebrand factor. I can't release PGI2 and nitric oxide, and I have tissue factor. On top of that, so now, here's the vessel. Let's say here I kind of represent this area here that's injured. Here's the area that got kind of injured by the virus. I literally lead to everything in this area not being able to stop platelets from sticking. I have something that platelets love to bind to, and on top of that, I release tissue factor, which likes to push the coagulation cascade towards making a clot. All right, so now I have this endothelial area of injury, exposed to von Willebrand factor, tissue factor is released, and on top of that, I got fibrinogen that's being pumped out from the liver. All of these things here And fibrinogen here is one of those really critical things that we need to make fibrin lead to what type of effect? Oh, dude, I'm gonna get a clot, thrombosis. And that's really the concern here, is now I have a person who can present with a thrombosis. And that's because we're kind of creating a hypercoagulable state. That thrombosis can then flick off emboli. And if that emboli flicks off, then I can spread these all over the body. And then I increase the risk of emboli. Why is this an issue? The reason why is when a person has SARS-CoV-2, the cytokine storm is really perpetuating all of this. The virus is causing its damage on the endothelium. The cytokines are worsening pretty much everything. On top of that, cytokines are also driving this process too. They're also, not only is the virus doing it, the cytokines are also worsening all of this. When you get emboli and thrombosis, you increase the risk of what kinds of conditions? Well, the result here is I can end up with things like DVT, PE, I could end up with a ischemic stroke. I mean, the list goes on. You're basically increasing the risk of getting clots all over the place. And that is what makes this disease even worse, because if I have a clot that's in the pulmonary artery and the patient also has ARDS and pneumonia, oh my gosh, I'm gonna worsen everything. All right, so that's why I'm trying to get you guys to understand this. The benefit of this is that when a patient comes in who has a positive COVID-19 testing, and they have symptoms of maybe pneumonia, or they have symptoms of ARDS, you're gonna need to get a chest x-ray to really see if they have any features of diffuse infiltrates. If a patient has labs drawn like CRP and ferritin and fibrinogen levels, and another one, here's another thing. Whenever you have a heavy clot burden, what's one of those factors that's actually made as a result of a little bit of fibrinolysis? There's one other thing that's actually made, and that is D-dimer. So a D-dimer is basically a breakdown product of fibrinolysis, and that occurs when you have a heavy clot burden. So you're also gonna notice that these patients will have a elevated D-dimer. So sometimes what we'll do is in patients when they come in, we'll get their CRP levels, we'll get their ferritin levels, we'll get their fibrinogen levels, we'll get their D-dimer levels, because it tells me, do they have a lot of this cytokine storm going on, which increases a risk for hypercoagulable state, getting thromboemboli. Okay, the next thing is, these cytokines can also act on your systemic vasculature. And when they act on the systemic vasculature, they do two components here. One is they make the vessels super dilated. All right? So now what I'm gonna do is I'm gonna make these, I'm gonna over exaggerate it, obviously. We're gonna make this thing super dilated. And on top of that, we're gonna make it leaky. All right? So two things happen here. One, vasodilation. Two is systemic capillary leakage. All right? So let's write this down. Vasodilation and an increase in the capillary leakage. The problem with both of these mechanisms is if I make the vessels really dilated and I really make them leak, what happens to my blood pressure? Well, systemic vascular resistance goes down, effective arterial blood volume goes down. Either way, the patient's blood pressure, which one of the best ways that we can look at blood pressure, especially as a perfusion component here, is mean arterial pressure. Mean arterial pressure, that's their blood pressure that determines the perfusion to the organs. So their mean arterial pressure will go down. If they have terribly high levels of these cytokines, mean arterial pressure will go down from vasodilation to capillary leakage. That mean arterial pressure, if I don't have enough perfusion to organs, the organs begin to become ischemic. Oh shoot. If I have organ ischemia or I'm not delivering enough oxygen to the brain, this can lead to encephalopathy. If I'm not perfusing the kidneys, I can end up with an acute kidney injury. If I'm not perfusing the liver, it can end up with an ischemic hepatitis. If I'm not perfusing the myocardium, I can end up with myocarditis. And sometimes in severe periods of this, I can even have arrhythmias. This is what I'm trying to tell you guys, is you'll notice something kind of interesting here. The virus itself has the capability of causing acute kidney injury, myocarditis. If I add a cytokine storm into the mix here, I can worsen their acute kidney injury. I can worsen their myocarditis. The cytokine storm causes 3 big things I need you guys to know. When a patient gets infected with SARS-CoV-2 and they develop COVID-19, what really makes it dangerous is not just the direct damage of the virus. It's the cytokine storm that can cause diffuse alveolar damage, which can cause ARDS, endotheliitis or endothelial dysfunction, which can create a hypercoagulable state, and systemic hypoperfusion, which can lead to multi-system organ dysfunction. I mean, here's another thing. Look, if I don't perfuse tissues, one of the easiest ways for us as clinicians to check to see if tissue perfusion isn't occurring, it's just easy for us to do, is a lactate level. Even that would be a potential sign of poor perfusion to tissues. But obviously looking at the patient to say, hey, they're confused, they have an altered mental status, they have an increase. So here, this would cause altered mentation, this would cause a bump in the creatinine, a decrease in the urine output, this would cause LFTs to go up. This may cause, I mean, heck, you could see ECG changes. You could see an increase in their troponins. You guys get the point. Is if I look at all of these, I may have a patient who has an elevated lactate, altered mental status. They may have some abnormalities in some of their labs or testing. So I may see increased creatinine, decreased urine output, a bump in the LFTs, an increase in the troponin, EKG changes. You guys get the point. This is a sign that a patient has more of that critical COVID-19, all right? And that's what I want to move on to next. The next component is when a patient comes in, they get infected with SARS-CoV-2, it binds onto the ACE2, it creates a cytokine storm, they can get the potential to be really, really sick. Some patients don't present sick at all, and they don't have any symptoms. That obviously depends upon the patient and depends upon the variant, that SARS-CoV-2 variant. We know that Omicron technically has less of that pathogenicity. Asymptomatic individuals, really, all we're saying is they have a positive, testing. And the most common one, which we'll talk about this later, is they have a positive PCR or nucleic acid amplification test, but it's obvious. No signs and symptoms. Mild COVID-19 is they have a positive PCR, nucleic acid amplification test, but they have more, so positive PCR, nucleic acid amplification test, and upper respiratory tract infection symptoms, signs and symptoms. So this is an individual who comes up positive for COVID-19, but their symptoms are really fever, maybe a low-grade one, maybe malaise, maybe myalgias, maybe anosmia, maybe aguesia, maybe they have a sore throat, maybe they have a cough, maybe they have congestion, maybe they have diarrhea. It's very mild symptoms. There's no lower respiratory tract involvement. For the moderate one, they have a positive testing. So their PCR, nucleic acid amplification test, which is the gold standard, is going to be positive, and they have lower respiratory tract signs and symptoms. What do I mean? Maybe some pneumonia findings. What would that be? It could be things like a cough. It could be dyspnea on exertion. You may even get a chest x-ray of this individual and find that they have some type of ground glass opacities. The key thing here is not enough to cause hypoxia. So their SpO2 is greater than 94%. So they have a cough, they have dyspnea, maybe on exertion, but their SpO2 is fine. In the severe COVID-19, they have a positive PCR, nucleic acid amplification test, but at this point, and they have the pneumonia signs and symptoms, but at this point, it's more severe. It's enough that it's starting to cause damage to the alveoli. It's starting to get to that ARDS point where we're really affecting oxygenation. And now we're seeing the individual developing some of those similar findings. So what could this be? They could have, again, dyspnea, but that dyspnea maybe is at rest, which is not normal. They can have an increase in their respiratory rate. We say greater than 30, which is tachypnea, right? So an increase in the respiratory rate, also known as tachypnea. Or they have an SpO2 that is less than 94%. So do you see how here, no symptoms, very mild upper respiratory tract symptoms, no hypoxia, and signs of increased respiratory distress beginning to occur. Then we get to critical. At this point, they have a positive PCR nucleic acid amplification test, but they have a couple different things. One is they can have things like respiratory failure, so ARDS, but now they're requiring heavy oxygen support. So the way I would say that is they have respiratory failure requiring, and I'm going to abbreviate this, invasive mechanical ventilation. They have to be tubed. The second thing is they have multi-system organ dysfunction. This is probably because they have hypotension, they have thrombosis. So this is probably a combination of due to thrombosis from the endothelial dysfunction creating a hypercoagulable state and hypotension, the shock state from the systemic hypoperfusion, the vasodilation, increased capillary leakage. Kind of like it's like a distributive shock kind of presentation. This is what you get worried about. So if I had to tell you, Zach, hey, can you tell me again, the particular clinical findings that help me to stratify where the patient lies in having COVID-19? Asymptomatic, it's just a positive test, no symptoms. Mild is upper respiratory tract. Moderate, lower respiratory tract, but no hypoxia. Severe, lower respiratory tract with hypoxia. Critical, they have severe respiratory failure that they're having to utilize. Either they're rapidly deteriorating and they're on high flow BiPAP, or they're intubated, or they have hemodynamic instability and multiple thrombotic kind of complications that are causing multi-system organ dysfunction. Now, we've talked a ton about COVID and really what it is, how you get it, how does it actually cause disease, the mechanisms of severe disease, what that could look like. And really the overall classic clinical presentation, but complications, we kind of covered that intrinsically, right? And what do I mean? The big complications that we get worried about first is ARDS. We talked about that. That's with the diffuse alveolar damage. So you get direct injury of the lung tissue from the virus and then a cytokine storm. The other one is you get thrombosis. This is that hypercoagulable state that's due to the, again, cytokine storm and damage from the virus. And then on top of that, you can end up with the multi-system organ dysfunction. And this is probably due to systemic hypoperfusion and clots that are occurring in those vessels that are causing organ ischemia. And again, we use this example as things like AKI, myocarditis, right? Ischemic hepatitis, the list goes on. So this has already been discussed, right? We don't need to go hepatitis. We don't need to go through that part again. What I do want to talk about is some very unique, interesting complications that can occur as a result of COVID-19. One is called multisystem inflammatory syndrome in children. We are seeing this in adults. It just happens to be one that we get really concerned about in children. What happens is probably a couple weeks. So what happens is the first thing is they get COVID-19 infection. And then probably 2 to 6 weeks later, they end up with worse symptoms. And what I mean by that is they look absolutely terrible, all right? The symptoms that they'll present with is things like a fever, rash, and low blood pressure. Honestly, it kind of looks like a Kawasaki. Like they can have like a fever, they can have a rash, they can have conjunctivitis, they can have cardiogenic shock. They literally almost look like a Kawasaki disease or toxic shock syndrome kind of presentation. And it's pretty concerning. And then abdominal pain. That's a pretty big one, abdominal pain. The concept behind this is kind of really weird. What's thought, and I don't want to go into too crazy of a detail here, but it's thought that the virus can live in these enterocytes for a while. So you get the infection, you think that you clear it, but you actually don't clear it. And what happens is the viruses, they're living in these enterocytes. So some of these viruses are living in the enterocytes. And then what happens is the virus releases things, it triggers the enterocytes to release something called zonulin, which is the theory behind it, is these epithelial cells, or these enterocytes, they increase the expression of something called zonulin. And what zonulin does is when it's released by these cells, is it kind of increases the permeability. It kind of makes spaces between these enterocytes. So that's what zonulin does, is it kind of creates these little spaces, if you will, between the cells. If I increase the spaces between these cells, I increase the permeability and things can cross over. And when these things can cross over, especially even from these cells, you can release these viral antigens. And when you release these viral antigens, I'll just represent them in purple here, they get into the bloodstream. And then what happens as a result, if I can kind of slowly release these viral antigens a couple weeks later, I create a inflammatory response. Right, because I'm going to expose them to things like spike proteins. And that's going to cause this inflammatory response, and that inflammatory response is what leads to this multi-system inflammatory syndrome in children. So again, the thought behind this is they get an infection, the virus survives and kind of acts as a reservoir. Your intestinal epithelium acts as a reservoir for that virus. They release zonulin as a result of being infected by the COVID-19, or kind of holding it there and reserving it there. The zonulin increases the permeability of the gut lining. Viral antigens can get into the bloodstream and increase this inflammatory response. And that's why they'll end up getting symptoms 2-6 weeks later. And I'm not kidding, it's terrible, terrible symptoms where they can actually look terribly, terribly bad. This one you have to treat with IVIG. All right, so intravenous immunoglobulin. Sometimes we even have to do steroids in combination with that. All right. Long COVID, this one's interesting as well. Long COVID is kind of a similar concept to this, where what happens is the virus, basically you think that you clear it, and what happens is the virus lives in these areas. It's just like this. The virus kind of has these little reservoirs where it lives in the intestinal epithelium, it lives in your central nervous system, it lives in your lymph nodes, it lives in the endothelium. And then every now and then after you've actually, so you have, again, it goes like this. You have one is the COVID-19 infection. And then the component of this is second is you have symptoms for greater than 4 weeks. It's continuing to persist. So you end up with COVID, but these symptoms just don't particularly go away. And they're very unique symptoms. And so what happens is, the thought is that these viruses are living in particular reservoirs, like your GIT, probably most common, in your brain, in your lymph nodes, in your endothelium. And then just small amounts of these viral antigens are being released into the bloodstream. And when they're being released into the bloodstream, it's creating an inflammatory response. That inflammatory response is causing dysfunction in the microcirculation, and you end up with particular symptoms that persist for a while. But again, this is what leads to that inflammatory response. Is that they're kind of just, these reservoirs are just leaking this stuff into the bloodstream that's activating an immune response. And that immune response is causing microvascular dysfunction. Some of the symptoms is things like brain fog. So they kind of just have they don't remember things. They have post-exertional malaise. They're just really, really tired. Maybe they have persistent loss of taste and smell. They can have dysautonomia, where they can have an increased heart rate and a low blood pressure. It's just very prolonged symptoms that are continuing to occur even after they've been infected with COVID for at least 4 weeks or even longer. And that's what makes this one kind of interesting. So that's what I want you guys to take away from all of this with COVID-19 is we talked a lot about the virus. We talked about a lot about the particular components of the virus, the risk factors for severe disease. We went through the life cycle. We went through what tissues it damages. We talked about the mechanism of how you can actually get a very severe type of COVID-19 infection. We talked about the classic findings that you would see with an asymptomatic, mild, moderate, severe, and critical COVID. And we talked about complications already with this, and we talked about these unique ones. What I want to do now is I want to put all of this together and come up with a way of being able to approach COVID-19 as a clinician and then talk about how we treat it. Let's do that now. All right, my friends, let's talk about the diagnostic approach to COVID-19. So we've talked a lot about the pathophys, we talked about the clinical manifestations, we went over the complications, all of those risk factors. The key thing here to remember is the patient presenting with signs and symptoms of COVID-19, right? And we talked about a lot of that. So that's the patient who maybe presents with potentially upper respiratory tract infection symptoms. Maybe it's a sore throat, maybe it's a runny nose, maybe it's congestion, maybe it's a headache, maybe it's some muscle pain, maybe it's a high fever, anosmia, aguesia, diarrhea, things of that nature. That's one reason that you'd want to test this patient. Another one is that they have close contact. So they were around somebody that tested positive for COVID-19. COVID-19 is very easy to be transmitted from one person to another via respiratory droplets or fomites. So again, close contact or signs and symptoms, you need to test them. Now, when you test a patient, there's two different tests. You can do the rapid antigen test. It's just the sensitivity for that one is a little bit lower. So if it is negative, you can't completely rule it out. You may have to repeat it in a couple days later, or just go to the gold standard, which is the nucleic acid amplification test, or that PCR. And that's going to be via a nasopharyngeal swab. You're going to swab back there, you're going to take that actual sample, and you're going to test it to see if I can find that particular virus. All it does is it takes the specimen, it actually isolates the actual nuclear material, amplifies it, and sees it comes up, particularly on these particular probes, to say, oh, I definitely have the actual genetic sequence in this case for something like COVID-19 or the SARS-CoV-2. So that's the key here for that one. Now, if that test comes up positive for that nucleic acid amplification test, or let's say that you get the rapid antigen detection test and that is positive, then you can say with relative certainty that the patient has COVID-19. So if they have symptoms or they have close contact, you get the PCR, nucleic acid amplification test, comes up positive, good, you have COVID-19. The next question that you have to determine, because it determines your decision making, is how sick are they? Because that determines if you're going to hospitalize the patient, that determines if you're going to have to do more testing on the patient. And so that's really critical. So first thing we want to know is, are they maybe asymptomatic? And this was just a close contact exposure. I'm not going to do anything except, hey, maybe you should quarantine and just watch for supportive care, right? So if there's no symptoms, there's no hypoxia, that's great. For the mild one, they probably have upper respiratory tract symptoms. Again, that sore throat, fever, maybe they have anosmia, aguesia, maybe they have some congestion, some runny nose, a cough, things of that nature. Okay, as long as they're not hypoxic, cool, send them home, quarantine, supportive care. The next thing is the moderate one. This is the patient that maybe is starting to show some lower respiratory tract involvement. Maybe they have some pneumonia symptoms. Maybe it's a little bit of a dyspnea, right? Maybe it's a little bit of a cough, but they don't have any hypoxia. All right, that's still a patient I'd want to keep an eye on. I might need to just do some imaging and maybe some labs just to see where they are. Depends. But the biggest thing is that they're not hypoxic. When I get to the severe COVID-19, that's when I'm worried that the pneumonia symptoms are progressing. So they have cough, they have dyspnea. And on top of that, maybe they're showing some signs of a little bit of increased work of breathing. Maybe they're a little bit tachypnic. The respiratory rate's going up. They're greater than 30. And that big parameter, the easy one to remember, is that they're hypoxic. Maybe the SpO2 dropped to less than 94%. So when a patient starts showing signs of hypoxia or increased work of breathing, that's a severe COVID-19 patient, and I'm starting to get concerned. Critical is a patient who presents with, I'm talking very severe symptoms. And what I mean by that is they're showing signs of ARDS, right? They're acutely hypoxic. There's refractory hypoxemia. They are really working hard to breathe. they're hypotensive, tachycardic, that's another person that I'm worried about maybe a multi-system organ dysfunction or failure. And the other one is when I actually have evidence of organ failure. Maybe this is altered mental status. Maybe this is acute kidney injury. Maybe this is I have ARDS and I'm involving a bunch of other organs as a response to that. That is when I'm concerned that the patient has critical COVID-19. So again, the big thing to determine out of this is why I'm doing all of this is it determines what's the next step. Anybody who falls within that kind of moderate to critical range, I probably am going to want to do a little bit more workup on. So if they fall within that range, the next thing I'd want to do is just, hey, let me get some labs, let me get some imaging. The big purpose of doing this is that sometimes the labs will give you some kind of concept. It's always good to get some baseline labs, especially if the patient gets admitted and they need some kind of follow-up. CBC for these patients, especially the sicker they get, that tends to show leukopenia, so a decreased white blood cell count. When you get that patient who has that, again, maybe signs of multi-system organ dysfunction, we know that COVID-19 has the ability to attack the kidney cells on its own, but it also produces that cytokine storm that can also worsen kidney injury. And so in these patients, it's very, very critical to look at their renal function. Sometimes they can have an acute kidney injury due to the virus cytopathic effect on its own and that cytokine storm. So look at the creatinine, look at the BUN. The other thing is in patients who have that cytokine storm that they lead to severe hypotension, they don't perfuse their liver. You want to watch out for any evidence of increased LFTs. So that could be an indicative of an ischemic hepatitis. The other thing is it's really important to look for these inflammatory markers. A lot of them out there, there's so many of them, but all these tell us is the risk potentially of microemboli or multiple microthrombi all over the place. And it's really kind of a marker of badness due to that cytokine storm. So it's really good to look for things like CRP, which is that acute phase reactant protein, ferritin, which is an acute phase reactant protein, fibrinogen, which is an acute phase reactant protein, and LDH, which is kind of a marker of overall injury to a tissue. If these things are elevated, it really portends potentially a higher risk for things like a hypercoagulable state. It portends a higher risk of things like maybe multi-system organ dysfunction. And that's really, really, really critical to kind of identify these. The next thing is also a coagulation panel. Because COVID-19, again, has the ability to damage the endothelium, it can cause potential endothelial dysfunction. It can increase tissue factor production. It can also cause exposure of von Willebrand factor. And on top of that, from the cytokine storm, it can cause the liver to increase its production of certain types of acute phase reactants like fibrinogen. All of these things increase the risk of forming thrombi. And that is really important to be able to get an idea of that. So fibrinogen is a really good one, and a D-dimer is a really, really good one to look at. The higher that fibrinogen, the higher the D-dimer, the higher the risk of that hypercoagulable state. Again, it all goes in line here, this whole component, with that cytokine storm. And again, procalcitonin is one of those that people may throw out there. You got to be careful. It's been shown that sometimes COVID-19, for the most part, it may be normal. It could be a little bit lower. That could suggest more of a viral pneumonia, but that's not always perfect. The reason why we like this is that sometimes if you have a higher procalcitonin level, it could potentially suggest a bacterial pneumonia or a concurrent bacterial pneumonia that resulted as a post-COVID kind of like a pneumonia. So again, the big things I want you to take out of getting these labs is look for potentially acute kidney injury and look for evidence of that cytokine storm. That's really going to give you some information of whether you need to be a little bit more on alert for this patient. Okay? The best thing to look at is the imaging. If I have a patient who has a chest x-ray, especially who is presenting in that moderate, anywhere to the critical range, I'd like to get a chest x-ray first. It gives you a lot of information, especially if a patient is dyspneic, especially if the patient is hypoxic, if they're working hard to breathe. And what you're going to look for is these bilateral ground glass opacities. When you look at this patient's lung, you'll be able to tell, look at how diffuse this actual kind of like overall opacity is. It's very, very diffuse. You compare this to a normal chest x-ray, it's night and day. You can see crisp costophrenic angles, the heart kind of like overall contour, and you can appreciate that lucency. Over here, I have all of this kind of like white opacities diffusely spread throughout the lungs. It's kind of shading out the heart borders, maybe shading out a little bit of those costophrenic angles, but that's a clear sign of a diffuse interstitial infiltrate. And that's something that you would see for COVID-19. All right. The other thing is, if you ever did get a CT scan for these patients, you'll still see those ground glass opacities, and they're kind of interesting, but sometimes you may see this, what's called a crazy paving pattern. And sometimes this is somewhat kind of like, somewhat pathognomonic, but it's not always perfect. So here you can appreciate these ground glass opacities. It's this kind of grayish appearance here of the lung. You can see maybe a little bit of normal lung aerated tissue, and all of this is kind of evidence of that diffuse kind of infiltrate. And then over here, you can appreciate it really well. You can see these lines that kind of are separating the lobules apart from one another. That's that crazy paving pattern. And that's kind of basically the thickening of the lobular walls. And on top of that, intermixed in that is the ground glass opacity. And that's pretty suggestive for COVID-19. So first thing, symptoms or close contact, test them. If they're positive, next thing, assess the severity. If they have pneumonia symptoms, or they have hypoxia, or they have critical findings, they have respiratory failure, they're hypotensive, there's organs that are failing, you get labs. You check the labs mainly to look at the inflammatory markers in the coagulation panel. This is going to be your big thing that you want to see. And you get the images to find diffuse infiltrates in the form of ground glass opacities and sometimes interlobular thickening with that crazy paving pattern. That is the goal for this. Now, once you find those things, the next thing that you have to determine is, do I need to do more of a workup on this patient? And that really comes down to their symptomatology. So this is where we can get kind of like really in depth. If a patient presents with that refractory hypoxemia, then the concern is have they progressed to ARDS? That's always the concern. And again, the workup here comes from getting that ABG. You've already had the chest x-ray showing the diffuse bilateral infiltrates. You have to then show again, do they have refractory hypoxemia that's present on their ABG? So a PaO2 less than 60 millimeters mercury. If I get the PF ratio, it's going to be less than 300. If that's the case, and it's acute onset, and I ruled out a cardiogenic source, that's my concern, is that they have ARDS. Other things that you want to watch out for is that in patients who have underlying conditions, things like CAD or CHF, they can end up with exacerbation. So if a patient presents with chest pain, you want to watch out because COVID-19 can also damage the myocardium itself. And when it damages the actual cardiac muscle, it can lead to myocarditis that can push the patient into acute heart failure. It could cause arrhythmias. And so that's what I want to watch out for. So I like to get an ECG, make sure that they don't have any ST changes, and get the troponins to find any kind of injury to the actual myocardium. So you'll see maybe an ECG will have some ST changes. They may have some arrhythmias, but the troponin also, usually in myocarditis, because there's damage to the myocardium, they may have a troponin leak as well. Another thing is that if a patient has hypoxemia, they have pleuritic chest pain, they have tachypnea, and that concern here is pulmonary embolism, which is very common with COVID-19. COVID-19, because it has that, again, ability to increase the hypercoagulable state, it can cause microemboli and thrombi, especially within the pulmonary vessels, but it can form all over the place. So pulmonary embolism is definitely concerning. So in this patient, I would have to get a CTPA, a CT pulmonary angiogram, and look for evidence of a filling defect that's kind of blocking off that particular area. And that's another thing I would actually want to consider. The next thing is if a patient had a productive cough, if they had a lobar consolidation on their chest x-ray, and maybe they had a fever, well then my concern is, do they have a secondary bacterial pneumonia? This can happen. Just like you get post-flu pneumonia, you can get post-COVID pneumonia that actually is due to a superinfection by things like MRSA or streptococcus pneumonia. So what I would do is again, if I haven't already, I get a chest x-ray and I would probably get some sputum cultures and to see if it comes up positive for the particular likely pathogen. Things like MRSA and things like streptococcus pneumonia are very common as a post-viral bacterial pneumonia. All right. That's really critical to think about these when a patient comes in. So again, to recap what I want you guys to think about with this, patient has symptoms of COVID-19, you're going to test them. If they have close contact, test them. Do it with the nucleic acid amplification test or PCR. It's the better test. If it's positive, they have COVID-19. Then you determine their severity, because if they're in the moderate to critical range, so again, pneumonia symptoms, hypoxemia, multisystem organ failure, get the imaging, get some labs. The big thing for the labs is looking for signs of inflammatory markers. That tells you that they got a cytokine storm that's a kind of a brewing. They may have high risk for thrombi. They may have high risk for ARDS. They may have a high risk for systemic hypoperfusion. If you look at their chest x-ray, you see the bilateral ground glass opacities. You see that crazy paving pattern. That's also really suggestive of a COVID-19 kind of pneumonia, and they can progress to ARDS. The big thing is that you need to be willing to work these patients up if they show signs of ARDS. Getting an ABG, ruling out a cardiogenic source. Making sure that if they start having arrhythmias, chest pain, ST changes, you work them up and consider things like myocarditis. If they start having pleuritic chest pain, tachypnea, refractory hypoxemia, consider a PE study. And if the patient also is showing signs of a productive cough, they have a lobar consolidation that's really getting dense, and their fever is really going up. Maybe they have a leukocytosis. Maybe their procalcitonin has shot up. Then you may want to consider like a bacterial pneumonia that's secondary to that post-COVID infection. Get the sputum cultures. And again, the goal of all of these things is it could change the patient's management. That's why it's important. All right, so now let's talk about how we treat COVID-19. In order for us to do that, we need the actual life cycle in front of us. So again, you remember on this epithelial cell, we have that ACE2. ACE2 binds to the spike protein on the SARS-CoV-2. That allows for them to attach. Once they attach, there's two ways by which the virus gets into the cell. If it's the alpha, beta, delta variant, it uses the TMPRSS2 to prime it. It cuts the S2 subunit and allows for it to fuse with the cell membrane, and that'll release that viral RNA in. If it's the Omicron variant, it's gained an ability to avoid the TMPRSS2 priming, and it actually just undergoes direct endocytosis, all right? Either way, they get into the cell. From here, they release their RNA right into that cell. Once that RNA is in, that RNA then needs to be able to utilize particular processes to replicate itself and make more viral proteins to assemble a new virus and then go spread to another cell. How does it do that? Well, that goes to the actual host ribosomes and translates some of that single-stranded RNA into a big polyprotein. The other thing that happens is there's a protease enzyme. The protease enzyme then takes and eats that polyprotein and breaks it up into small pieces, these non-structural proteins that we're going to utilize as kind of enzymatic processes. One of those is going to be helpful because it's the RNA-dependent RNA polymerase. And what this dude is going to do is what? It's going to take the single-stranded RNA and it's actually going to convert it into mRNA. mRNA is then going to go find ribosomes that are present on the rough endoplasmic reticulum and get translated and make the actual structural proteins. It'll make the spike protein. It'll make the membrane protein. It'll make the envelope protein, right? And then those are going to get packaged by the rough endoplasmic reticulum into a vesicle. The RNA-dependent RNA polymerase is also going to take the single-stranded RNA now, and it's going to replicate it. And it's going to make multiple strands of that single-stranded RNA. Now what happens is I have the RNA, I have the proteins, I'm going to have them do what? I'm going to have them meet at the Golgi. So it's right at that actual complex between the rough ER and the Golgi. They meet and they move into the Golgi and everything gets assembled. From there, it then goes to the cell membrane, undergoes exocytosis, and you pop out that virus. This is where we need to understand something. What if I could now attack this virus at multiple different stages? So we have antivirals, and this is going to be things like nirmatrelvir and ritonavir, also known as Paxlovid. So it's a combination drug that's actually really kind of cool. What these drugs do is very interesting. Now, the liver has an enzyme called the CYP3A4, and that metabolizes nirmatrelvir into its kind of broken down form. So it's going to be less effective in that scenario. Well, what if I gave a drug like ritonavir that inhibits the CYP3A4 enzyme? Now, nirmatrelvir won't be metabolized as much, and the levels of nirmatrelvir will go up. All right. Now, that nirmatrelvir, what does it do? It actually comes right over here and inhibits the protease enzyme. If I inhibit the protease, can I break down the polyproteins and make my non-structural proteins? No. Can I make the RNA-dependent RNA polymerase and other proteins and enzymes I need? No. Can the virus then go through and make its RNA and make its proteins it needs to form a new virus? No. The next drug is remdesivir. Remdesivir is great because it directly inhibits RNA-dependent RNA polymerase. And now it can't take that single-stranded RNA and make mRNA. So then it can't undergo the translation process. It also can't replicate the RNA. And by that default, we can't make new viruses. That's the benefit of these two antivirals. All right? Other drugs that we want to give is, again, the virus produces a cytopathic effect itself on the upper respiratory tract, the lower respiratory tract, the myocardium, the GIT, it also works on the kidneys. It works all over the place, right? The endothelium, it can damage a lot of tissues directly. And so this may reduce the damage from that. But sometimes when the damage has already been done, you trigger a massive inflammatory response, referred to as that cytokine storm. What if we could give drugs that could modulate that cytokine storm? Well, again, you got to remember this virus, it attaches to these epithelial cells. The biggest and scariest one that we get worried about is these type 2 pneumocytes, the alveolar cells in the lungs. When it does that, it gets in there, it triggers damage to the type 2 alveolar cells. What we know is that the type 2 alveolar cells make surfactant. If you can't make surfactant, what happens to your surface tension? Goes up. If your surface tension goes up, can you keep the alveoli open? No. What do? They collapse. That right there contributes to an overall effect in reducing recruitment of the alveoli. And now it's harder to oxygenate your blood. The other concept here is that whenever these cells are damaged, they release damage-associated molecular peptides, they release pathogen-associated molecular patterns. All of these things act on macrophages within the alveoli. When it acts on those alveolar macrophages, they then respond with a very aggressive hyperimmune response. And they pump out things like interleukin-1, they pump out interleukin-6, and they pump out tumor necrotic factor alpha. The big culprit here that we find is interleukin-6 tends to be a little bit more problematic than I think the rest of them, but we'll get to that. What these things do is they basically create this systemic and localized vasodilation, pulmonary capillary permeability, and a hypercoagulable state. I'll explain. Let's say that this works in the lungs. So all of these cytokines are being released all over the lungs. It's going to basically cause the pulmonary vessels to become dilated and leaky. The fluid's going to leak out of those pulmonary capillaries into the alveoli, and now the alveoli is going to be consolidated and filled. So now you got alveoli that are filled throughout the lungs, and you got alveoli that are collapsed throughout the lungs. That is a recipe for ARDS, all right? That's where we start to see ARDS is from this diffuse alveolar damage due to the damage from the virus and the cytokine storm. Now, the other thing is that these cytokines also act on your systemic vessels and cause them to dilate and also become leaky. Now, fluid starts leaking out of the vessels. If you dilate your vessels, what also happens to your systemic vascular resistance? That goes down. Then your blood pressure goes down. If your blood pressure goes down, what happens to your organ perfusion? That can decrease, and you can start to see multi-system organ failure. This could be the brain. You're developing an altered mental status. You could see lactate elevation. You could see an acute kidney injury. You could see ischemic hepatitis. You start to see a lot of issues arise. All right. The other concept here is that these cytokines also do work on what? Well, you have to remember that the actual virus itself can induce thrombosis via endothelial cell dysfunction. That's one thing that we said, right? It does that by damaging the endothelial cells. They no longer can release prothrombotic, antithrombotic molecules like PGI2 and nitric oxide. Platelets stick, the exposed von Willebrand factor, platelets stick. You also cause these cytokines to trigger the production of fibrinogen and maybe other coagulation proteins. And all of these things, the cytokine storm and the direct viral injury itself to the endothelium leads to thrombosis. The problem with thrombi is that they can pop off, right? So again, tissue factor, fibrinogen, endothelial dysfunction, we talked about that. But the biggest thing with thrombosis is the popping off of it and forming emboli. And these can form all over the place. If you get a big one in the leg, you get a DVT. If it breaks off and flies up to the pulmonary arteries, you get a PE. If they get stuck somewhere within the actual circulation, you can get a cerebrovascular accident. And you can get microemboli that are all over the place. It could be in the fingers, it could be in the toes, it could be in the kidneys, it could be in the liver. It could be literally anywhere. And that's what makes this condition super dangerous. Now, this is really the effect of this cytokine storm. But I want to zoom in and say, okay, how a lot of this stuff happens really comes down to how these maybe work at the cellular level. But the big culprit that we tend to look at a lot is interleukin-6. Interleukin-6 tends to actually act on these cells by binding onto an interleukin-6 receptor. When it binds onto the interleukin-6 receptor, it's supposed to activate a jaundice kinase enzyme, JAK2. JAK2 then activates STAT, the signal transducer activator of transcription. That then signals the nucleus to then trigger the production and undergo its process of making particular proteins and cellular responses that are very critical. And in this case, the cellular responses is everything that we just talked about. It leads to this crap. What if I had a drug that could block interleukin-6? All right, that would be super helpful. So now let's see how we utilize these drugs to come into play. The first one that is the most recommended, has been shown to reduce mortality, is dexamethasone. Dexamethasone really works by kind of shutting down the cytokines very, very high up. So what dexamethasone does is it kind of shuts down the cytokine production. And so you may see a reduction in interleukin-1 and interleukin-6 and tumor necrotic factor alpha. And by default, you'll see maybe reduced diffuse alveolar filling, reduced systemic perfusion. You'll see a reduced hypercoagulable state. You're trying to reduce the mortality factor that comes with corticosteroids or dexamethasone. All right, that's a beautiful thing, but what if I can now block it at this stage? That's where tocilizumab comes in. Tocilizumab is an interleukin-6 receptor blocker. So it's going to basically be a monoclonal antibody that binds onto this and blocks the interleukin-6 to interleukin-6 receptor connection. Now you can't signal the JAK enzyme, the STAT enzyme, and you don't produce a good cell response. The other one is baricitinib. Baricitinib directly inhibits the jaundice kinase 2 enzyme. If you inhibit this enzyme, you can't activate the signal transducer, activator of transcription, and you can't produce that cell response with these. And so by default, what do? You reduce the diffuse alveolar filling, you reduce systemic hyperperfusion, you reduce this hypercoagulable state that's caused by this cytokine storm. So that's the concept that I want you to understand. So when as a patient gets really, really sick, you're probably going to be on an antiviral and maybe one or two of the immunomodulators. If you're not as sick, you probably don't need these immunomodulators because you probably don't have that intense cytokine storm. So you probably only need one of these. As the patient gets really sick, using these drugs definitely helps to reduce the hypercoagulable state, but they're still super high risk for clots. And so oftentimes we need to use things like low molecular weight heparin as an anticoagulant to basically prevent that risk even more. And so these basically work by, again, not treating the underlying issue, they treat the symptoms. And so they're basically working to inhibit things like thrombin, particularly actually inhibiting factor 10, which then would inhibit the actual production of thrombin and again, reduce the risk of thrombosis. So that is where this low molecular weight heparin comes in, is any patient who is kind of maybe showing elevated cytokine storm risk factors. So maybe you're looking at that inflammatory panel, maybe you're looking at their coagulation panel, and you're seeing that those things are on the rise. They're looking a little bit sicker. They're in that moderate kind of category. You probably start low molecular weight heparin prophylactically right away. All right. That's the thing I really need you guys to understand here. All right. Now, with all of this being said, the next thing that's also really important is that COVID-19 pneumonia and ARDS can cause hypoxia. That hypoxia needs to be addressed. Anytime the patient has an SpO2 less than 94%, you put them on some form of oxygen. That probably can just start off as a nasal cannula. As the patient's hypoxia gets worse, and maybe they're on nasal cannula, then you can give them something like high flow nasal cannula. This is giving them maybe upwards of 50 to 60 liters, where this may cap out at around like 10 or 15. And sometimes if you have like a non-rebreather, those can go up a little bit as well. But nasal cannula, maybe potentially a non-rebreather would start off with. Then you go to the high flow if they're really hypoxemic, and you need to give them a heavy amount of flow and very high amounts of oxygen. Sometimes in certain scenarios, you can consider BiPAP. This is bi-level positive airway pressure, and you're going to be generating, not only you can control their oxygenation, but you're helping to ventilating them. You're giving them a good amount of what's called positive end expiratory pressure. Because those alveoli are collapsing, you want to keep them open and recruitable so that oxygen can run into them and then run into the pulmonary blood. So BiPAP would probably be another thing that could be considered. Usually when a patient is really struggling to breathe, they're refractory hypoxemic to all of these above therapies, then we may have to intubate them. So we'll do an endotracheal tube intubation, put a tube in, and then control their ventilation with a mechanical ventilator, where we control their tidal volume, their respiratory rate, their PEEP, and their oxygenation. So that's all things that would be controlled in these patients. And in worst case scenarios, sometimes if the patient has progressed to ARDS, we start to consider things like prone positioning. Now, in certain patients that maybe are in that kind of like, let's say they're in the severe COVID-19 COVID-19, they're hypoxemic, they have some infiltrates, they have shortness of breath, we do actually suggest things like awake prone positioning. So that can be utilized before you're even intubated or extremely critical. But again, the concept of prone positioning, I don't want to go into too much detail here because we talked about it in ARDS, is again, what you're doing is you're taking a patient who's in the supine position. When you have this COVID-19, what happens with these patients is that their lungs are consolidated in that posterior kind of dependent portions. And because of that, you have changes in the transalveolar pressure. And because of that, the blood flow going to those areas, you're getting mismatches in ventilation and perfusion. All we want to do is improve that ventilation perfusion matching. So when you flip them over, what you do is you allow for that dependent posterior portion of the lung to open up. And so now when it opens up, it's not going to be collapsed as much anymore. It's recruitable. And by doing that, you actually allow for this alveoli to participate in gas exchange better. So now there's a better transpulmonary pressure difference. And because of that, the perfusion and ventilation no longer have that significant mismatch and you get improved oxygenation. So that's something that we definitely have to consider. But again, we talked about that in ARDS. So a lot of stuff. What I want you to do is we understand now why we give these drugs, but it's important to have a systematic approach of when we give these drugs. So again, that patient who has the mild to moderate COVID-19. So this is the patient who is in the mild category, maybe it's upper respiratory tract symptoms, but they don't have any hypoxia. The moderate one is they have maybe some pneumonia symptoms, but they don't have hypoxia, but maybe they have an abnormal chest X-ray. In those patients, it's probably best to just do something like what? Well, if they're high risk, unhospitalized, you could probably just do the Paxlovid. So nirmatrelvir or with the ritonavir is probably going to be the go-to. Remdesivir is also a second alternative. And sometimes they even consider molnupiravir as well, but we don't often use that as much anymore. So nirmatrelvir, Paxlovid is probably going to be the number one, or remdesivir could be a second kind of runner-up in that scenario. As they get to that severe COVID-19, now this is the patient who has the pneumonia symptoms, they're hypoxic, they have an abnormal chest X-ray, CT scan, they're kind of a little bit more complicated. In that scenario, anytime a patient is hypoxic, they're going to need oxygen. So you're going to have to keep them in the hospital. They're going to then be admitted. If that's the case, the best scenario here is I could actually give something like dexamethasone because now they're showing signs potentially of a cytokine storm. The other thing is remdesivir because I want to give an antiviral agent to prevent the continuous viral application and further damage. The other thing is I may need something like what? Respiratory support. This could start off with nasal cannula. This could also potentially maybe escalate to high flow sometimes, but ideally you're probably going to just have them on nasal cannula, maybe a non-rebreather. And again, the goal here is use the one that top-down effect. The dexamethasone is going to really treat that higher up kind of cytokine storm. Remdesivir is the antiviral agent, and the respiratory support here, start off with your nasal cannula, and as you start to titrate up and you need things like high flow, we're starting to get into the critical time frame. Also, cytokine storms not only increase the risk of things like ARDS and potentially a systemic hyperperfusion, but they also increase the risk of clots. And so what would I want to have this patient on to reduce the risk, giving it prophylactically? Low molecular weight heparin. So again, this patient probably doesn't have a cytokine storm. All we need is antivirals. Nirmatrelvir, Paxlovid, or remdesivir. This patient, they have the viral infection, but they probably also have a little bit of a cytokine storm that's starting to brew. Give them that top-down immunomodulator, dexamethasone. Give them an antiviral to reduce the replication. Give them a little bit of oxygen, nasal cannula, non-rebreather. If you have to start kind of dipping into the high flow, you're starting to get worse. You're starting to maybe move into the critical range. And reduce the risk of developing thrombi prophylactically by giving them something like low molecular weight heparin. All right, so if they have critical COVID-19, it's really important to remember that they obviously have that cytopathic effect of the virus, but the cytokine storm is on full-fledged alert. So because of that, this patient is likely experiencing ARDS, they're probably experiencing systemic hyperperfusion, they have a very intense hypercoagulable state. Because of this, they're probably either on high-flow nasal cannula, and it's rapidly starting to increase their FiO2 requirements, the BiPAP, they're requiring high PEEP settings, high FiO2, their work of breathing is starting to get worse, and maybe in certain scenarios, they have to be intubated. Oftentimes, the patient may start off in this severe kind of COVID-19 category and then bridge themselves over into that critical COVID-19 category. Now, in this scenario, it's important to remember dexamethasone is still going to be needed. You have an intense cytokine storm. This is going to give that top-down effect. The other thing that's really important here is that remdesivir, if it was started when a patient had severe COVID-19, maybe they were on nasal cannula, maybe they were on a little bit of high flow, maybe they were on BiPAP, and they got intubated, or again, they actually had to be intubated right away. In technicality, remdesivir has shown to have no mortality benefit when the patient is already on invasive mechanical ventilation. If they were started on it when they were in the severe state or while they were on high flow or BiPAP, all you do is you continue remdesivir. That's really important to remember. You don't give it if they're intubated because it showed no mortality benefit. The next thing is, because the cytokine storm is the really problematic issue here, you need a second immunomodulator. That is where tocilizumab or baricitinib come into play. So if you remember anything for critical COVID-19 treatment, it's that you need 2 immunomodulators. That is the most important and critical step here. Dexamethasone for the top down, tocilizumab at the interleukin-6 blockage, baricitinib at the JAK2 blockage. That is the key. The next thing is obviously respiratory support. At this point, they're on high flow, they're on BiPAP, they're intubated, all right? And lastly, low molecular weight heparin for that anticoagulation control. So again, looking at this patient, they have no cytokine storm, just the antiviral. Here they have a little bit of a cytokine storm, antiviral, and give them an immunomodulator. A little bit of oxygen if they're hypoxic, and anticoagulation. Here, full-fledged cytokine storm, 2 immunomodulators. Only continue remdesivir if it was already started when they were on nasal cannula, high flow, BiPAP. If they were intubated already, you don't really need to start remdesivir. Only continue it if it was already started. Again, respiratory support, it's more aggressive. High flow, BiPAP, mechanical ventilation, and anticoagulation control. All right, that covers the treatment approach. It would obviously be ideal if we could prevent a patient from even developing COVID-19, right? That's the goal. So how do we go about doing that? Well, that's where vaccination comes into play, my friends. And there's mRNA vaccines. If you guys want to know a little bit about them, you can see that on our other videos where we talk about things like Moderna, AstraZeneca, etc. But there's mRNA vaccines, and there's actually Novavax, which is kind of like this protein subunit. Essentially, it's kind of the same thing. One is you're kind of like giving them a way of being able to produce these antibodies via the mRNA that's introduced. One of it's you're giving them proteins to produce the antibodies. But either way, you're introducing a vaccine to the individual for them to produce antibodies against what? Against this son of a gun, the spike protein. Other things that we may give in certain scenarios is pemivibart. It's a chemoprophylactic agent. Essentially, it's the immunoglobulin. You're not even giving the opportunity for the patient to produce the antibody, maybe because they can't. You're giving them a monoclonal antibody in this scenario, or an IgG antibody against the spike protein. You're not giving them a chance to produce it. So either way, in both of these scenarios, you're giving them an antibody. The vaccine, the body makes the antibody. The chemoprophylaxis is an artificially already made antibody. But what do? They bind to the spike protein. They block the spike protein from connecting with the ACE2. They can't attach, they can't get into the cell, they can't undergo that viral replication process. That's a beautiful thing. Now, with this being said, who do you give these to? The mRNA or protein subunit vaccines, it's any patient greater than or equal to 6 months of age. All right, that's really the key. That's the really important thing to remember. For the chemoprophylaxis, it's a patient who's not capable of responding to the vaccine and mounting a strong enough immune response to produce those antibodies. So you give it to them. You say, don't worry, put your immune system at rest. I got you. That is the thing that you want to remember. So again, for chemoprophylaxis, you're giving the patient the actual antibody. You're not letting their immune system generate it. Vaccine, you're giving it to the patient, expecting their immune system to generate the antibodies against that spike protein. That is the key thing here. My friends, we talked a lot about COVID-19. We went over the pathophys. We went over the complications, those who are at risk. We talked about the downstream consequences of this condition and what it really can do. We talked about the approach that whenever you have a patient who has symptoms or close contact, what's the testing? How do you assess the severity? When do you get labs and imaging? What do those labs and imaging tell you? And then what are the potential complications of this that I may need to do a further workup? How do I treat it and understand that treatment based on why I do it, and then understand it in a systematic approach of who I give this to. And then finishing it off with the prevention. What is the best way that we could attack this mechanism right from the beginning? And how do we do that? And who do we give it to? I hope at the end of this you understand that and answer those questions. And man, I love you guys for sticking around, hanging out. And as always, my friends, until next time.